Tonight is a very special night as we have guest stars from UK, from USA, and of course from Banha, Egypt. I'll let my friend, Professor Alam, the head of the planning, deformity planning and LRS unit in Banha Orthopedic Department to introduce our eminent speakers. Professor Alam?
Yeah, it's a pleasure to have with us today Professor Lahoti. It is not the first time for him to be with us, and of course will be with us several times more. We hope to be with us more times. Are you ready, sir, to start your talk?
Yeah, I'm ready. I'll start sharing my screen.
Yes, please.
Let me just share. Okay, can you see my screen then?
Yes, yes, sir.
Very clear.
Okay, so I'll start. Okay,
Yes,
well, thank you very much. It's always a joy whenever I meet Professor Hosni and everybody from Cairo. Wonderful time, wonderful memories. Anyway, let's get on with this evening's. I think it looks more pediatric today. I'm just both an adult and pediatric, and my training was in Sheffield, Children's Hospital, and Children's Hospital in Dublin. So, oops, let me just see. Okay, so today I'm going to just take you through the angular deformities around the knee, mainly Genu varum, Genu valgum, and recurvatum. I'm not going to talk about flexion deformity, which is 95% of the times is a soft tissue deformity. So I will stick to these three. We'll explore the causes of various deformities and how to diagnose and the pitfalls in diagnosis, and of course, treatment options. So Genu varum, I'll start off with, is common problem. Bow legs are commonly seen and a common presentation to clinic. Actually, they take more time often. It's often difficult to convince parents that it will go away, etc. So they take more time. You would rather sometimes feel that you could have done the surgery in shorter time than talking to parents, but it must be done. So most of them are physiological, and we'll explore how the physiological deformity pans out. And I say to my trainees that, don't ever ask an X-ray unless you've thoroughly examined. I would say 95% of the times Genu varum doesn't need an X-ray. So just spend time on assessing the child and the parents. So I'm sure every trainee in orthopedics would know this work by Selenius and Wonka. But there's some historic perspective to this. This was done in 1975 on American population, and they looked at, I don't know why they got so many X-rays, but they had X-ray assessment. So they gave us the prototype of what happens. So generally the human being, a human baby, is in varus at birth and slowly improves to neutral. And this happens between 1 to 2 years in Caucasian population. And then we start going into valgus, which is exacerbated valgus and called physiological valgus, and it could measure right up to 15 degrees. And generally it tends to resolve, again, in white population between 5 and 6 maybe. By 7, they reach adult angulation, which is generally 5 to 7 degrees. But as more studies are coming out, we know that not all children, all races behave similarly. So here is a study from Nigeria on the bottom left-hand side. Tella et al. Have presented a good study, I would say, out of 2,000 odd Nigerian children were measured. They didn't take X-rays. They used goniometers, intermalleolar distance and intercondylar distance, and gave us this. This is my own experience. When I first started in London, there were there's still, it's a big mixed population. And I used to overdiagnose blondes. And then I realized that Afro-Caribbean children develop more varus and later on, not here. they develop it later on, and then they linger on long. And in this study, by 7, there wasn't anywhere. So up to 7 sometimes. I think the peak is around 2, 3, 4. And that is to be kept in mind when diagnosing or over-diagnosing Blount's. And then there was a Chinese study, which again showed a very interesting finding that more Chinese kids are in varus for a very long time. You know, some of them have gone on to 11 as physiological varus and then improved. So this should be kept in mind. There was another study from India, which mimics more Caucasian, except that the degrees are slightly different. So when you see a physiological varus, it is age appropriate. That means depending upon the race, the child should be in that age bracket. And it is a smooth deformity, and it is often associated or almost always associated with internal torsion. By flexing the knees, you can see this very clearly here. So it's a smooth, no steps, and that is important to take on board. So this is another important thing to remember, the racial distribution of this deformity. So this is a textbook picture from Staheli's pediatric textbook. It clearly shows that this is a familial, like mother, like child. And you know, there's a debate in literature as to whether they should be treated or left alone. So this was another child who came to my clinic, nearly 4. And, you know, we were a bit astounded as to, you know, mother used to come, and then one day father came, and I just looked at father. I just said, show me your legs. And they look similar. So this is again a form of familial. It's not syndromic because his x-rays were normal. So remember these variations beyond physiological. So it's very important that a diagnosis is mainly by history and history alone of normal development, normal diet, no family of syndromes, no injury or infection, and generally the child is developing normally, then it's physiological. Clinical examinations should take place in standing, and you should see them walking, and then make them supine on the table and examine them in prone 2 for rotational profile. And by this time, one should be sort of confidently evaluate a physiological Genu varum. Long leg x-rays are only necessary if it is pathological, and even rarely MR and CT scan if you're looking for tumors and fusions. So the clinical assessment, if you want to document periodically, intercondylar distance for varus and intermalleolar distance for valgus is very important to so that the same person measures it, then the error is less. And when you're measuring intercondylar distance, make sure that the ankles are together. When measuring intermalleolar distance, knees are together and not, the limbs are not rotated. So other causes of Genu varum or pathological Genu varum is definitely the Blount's is the most commonest. We'll talk a bit more in detail in a minute. There are some syndromes, particularly achondroplasia, MUDs and SUDs. They are rare, but do pop in every now and then. And of course, trauma, infection, and tumor, they're generally unilateral, and the history is obvious. In metabolic problems, rickets results more in valgus rather than varus. Now, there are some rare causes at the bottom. So tibia vera, a Blount's disease, and the biggest problem is to differentiate between physiological and pathological or Blount's disease, you know, and I showed you the whole range depending upon the race. You need to be able to just be careful before branding a child. I'm aware of this angle. I rarely use it because it's very confusing. It also depends upon the rotation of the limb. And, you know, I didn't find it that helpful. So here is the clinical examination finding the lateral thrust. So if you see this video, look at that. Again, the child has that thrust. So that is not seen in physiological varus, and that should give you a clue as to whether the child has Blount's or not. Sorry. Okay, Blount's has been classified into infantile and late onset or adolescent form. Infantile is the most severe form, happens between 3 and 5 years of age. That's the presentation age. Of course, more common in African race. I've only seen one white girl in my 20 years in London. So, you know, it's almost given. It's bilateral in 80%, and girls are more affected than boys, and they are generally early walkers and slightly chubby. The older ones are, again, mild to moderate. Boys are more common, unilateral, and again, apparently we're seeing more in America because of adolescent obesity. Lung and skewer classification is well known, and it is time bound. As you progress towards the older age group, you see more advanced disease, and you know, type 1 to 3 much more reversible, but as you go beyond that, the changes are not reversible. So treatment goal of any angular deformity is restoration of alignment, leg length equalization, and maintain function. And that applies to every angular deformity. So treatment of early Blount's disease, in my rule of thumb, is I don't start any treatment before 3 years of age. I use brace only if I just need to buy time. Compliance is always an issue, and I'm not sure whether it works or not. I'll show you a case in a minute. And then there are a whole range of deformity correction options, and we'll talk about them too. So here is a child I saw early in my career, and I made this brace, and I knew, looking at the brace, every time she came to clinic, it was as brand new as given on first day. But, you know, mother said it's getting better. So I'm not so sure whether the brace has any role, but just be careful what you use it for, because quite often compliance issues. So the most popular treatment is definitely guided growth using H-plate. And here is a typical example. And it worked out very well because lung and skewer grade 2 at the most. But in severe forms, it does probably work more in the way of preventing further deformity rather than fully correcting. Here it worked out well, but it didn't correct or didn't reverse all the changes here, as you can see here. And you can use this method by taking out a screw. This is known as a sleeper H-plate. And if the deformity starts to recur, you can go and put a screw. And one of the biggest problems with H-plates is that overgrowth of the fibula in relation to the tibia and leg length discrepancy. And here we have another option of treatment. H-plate and osteotomy is an option. If you think that the wear has gone too far, you can correct wear acutely and stop it from getting worse. And the most severe forms need circular frame treatment, as in this case, you know, the child is much older, obese. I used a telospatial frame, and it worked out well. There's some talk about physial tether release. I haven't done one for Blount's, but the literature is not that encouraging. And there are other options like elevating medial tibial plateau, which to reverse the changes, the permanent changes you see in some Blount's. I've done probably 3 at the most, and I try and catch them early in our practice. So when do you suspect other causes of Genu varum, particularly if you're seeing a child who is short for his age and has got deformity? Then it should, you know, sort of light up in your mind to say, well, am I missing something here? Unilateral deformities, progressive leg length discrepancy, and, you know, then you have to assess both femur and tibia. Deformity could be in both bones or in femur rather than tibia. So mainly is a primary problem, individualized treatment, depending upon whether you want to do H-plate, osteotomy, or frame. And of course, there are a range of options guided by your own experience. So we move on to physiological valgum, our Genu valgum. And physiological is pretty straightforward in Genu valgum. All races should have done their various excursion, except in Chinese population by 7. And from 7 on, they look valgus, like the child on the right. And generally, the intermalleolar distance is up to 8 to 10 centimeters. Is a bit wide here, but angulation is no more than 15 to 18 degrees. So just observe and make sure that you see them 9 monthly or yearly. And by 9 or 10 years, they should finish that deformity. There's one variety which doesn't correct, or non-resolving physiological genu varum or genu valgum of adolescent age group. So the rule of thumb is that at 10 years, the intermalleolar distance should be 10. If it is beyond that, then we should start thinking about correcting them. And here is a typical example of a girl with pronounced genu valgum at nearly, she was 12. So I used 8 plates and got a very good result there. So it's often bilateral. Spontaneous correction is unlikely, so guided growth is important. Again, even in our place, rickets is quite common. Genu valgum is more common than genu varum. And as you can see here, ricketic rosary history is important. And there are other causes. I think one important cause I'll discuss in a bit more detail is Cosen's fracture. Again, these are all rare causes. And neuromuscular cerebral palsy is a completely different ballgame. So Cosen's fracture or Cosen phenomena happens after any proximal metaphyseal fracture, whether complete or incomplete. It progressively drifts into valgus. And most of that happens within the first 2 years. It goes into valgus and then comes back to this fracture deformity stage, in the sense, if you reduce the fracture very well, generally by 2 years, it comes back to that deformity or that status. If the initial deformity was, let's say, 10 degrees, then at 2 years, it will come back to that deformity. It's very interesting. It doesn't correct to normal. But if there's any residual deformity, do not correct it before 2 years, and guided growth works very well. So here is an example. Tibial fracture, very well reduced, both in lateral and AP views, and it healed very well, and then started to drift here, but I let it go until the child was nearly 11 and 12 years of age, and it wasn't resolving, and this is the result from a guided growth procedure. So when is osteotomy required in genu valgum? Particularly when the guided growth fails, or there is not enough time in a child within 1 year of skeletal maturity, unlikely to respond much to 8 plates. And it's important, once you get to that stage, very, very important to do long leg radiographs, and we have done malalignment tests on day 1, and that's what you need to do to locate the deformity. It's very important not to assume. The classic teaching is that distal femoral is the main source of deformity, but it might not be. Sometimes there are both tibia and femur involved too. The techniques for correction are osteotomy after failure of guided growth. It could be closed or open wedge, depending upon your fancy. I prefer closed wedge in older children. Gradual or acute, depending upon the magnitude. If it is beyond 20 degrees, I tend to do gradual. Under that, I tend to do acute. Always think of peroneal nerve, and you can decide whether you want to really correct, decompress it or not. So here is a child, not child, nearly teenager with this deformity. Although she had no symptoms, I know from the mechanical axis analysis that she's going to get into trouble in the future. So I slightly overcorrected on the right-hand side, and she's waiting for the other side. And this was a closing wedge osteotomy on the medial side. So remember, it's not always in one bone. It could be in multiple bones like tibia and femur. Here I started off very naively thinking that's a distal femur, because the child was too tall and we couldn't get his bottom, and I didn't do the analysis properly. I started off with distal femur, corrected with frame on one side, plate on the other side. This time it was opening wedge. And here we have this residual deformity. Then, after correcting it, it still looked a bit valgus. It was in the tibia. I obviously wasn't focusing there. I could have done it 2 together, but anyway, I finally went and did a correction, and that's the final correction. So we move on to now genu recurvatum. It's always pathological. There is no physiological genu recurvatum. So this is important to understand. And most of the times it's iatrogenic. In my practice, I probably see 1 in 5 years, and it's quite often a pin going through or somebody put a screw very close to it. And infection is also another source of trouble, but very, very rare. It's mainly the trauma. So here we are. This is a tibial avulsion fracture in a very young patient. Actually, it was pulling out from the very front of the physial plate, and it was fixed with compressive screws, and that either done the damage or the damage was already done to this area. And gradually, as you can see, the tibial slope reversed, and this is its clinical picture. And the typical giveaway on AP views is this sort of overlap. That means either there's a tibia recurvatum most of the times, and only rarely a flexion deformity. So here is another case where we used an Ilizarov frame to correct her Blounce, I think, if I remember right. My colleague didn't see the pins. I think one of the pins was very close to the physis. It was a scanned pin, so I wouldn't say it went through the physis proper, but it was very close here. And then gradually we started seeing this deformity. Here is the MRI scan. This is the only time I do MRI scan if I'm looking for physial tether. CT scan will also do. It's a very central, I think roughly occupies 30% of all this. And I didn't think physial tether would really help. She was also short, as you can see here. So I think when you have leg length discrepancy and angular deformities, circular frames are the best. You can correct both. So we did it with a circular frame. But there are other simple options. I'm not aware of any guided growth procedure, but there might be some people who can put clips at the back and see whether they would correct. Osteotomy and acute correction is the most common way of dealing with this. The first osteotomy was described was one of posterior closing wedge and translation, but more and more reports are coming of anterior wedge with opening and grafting and plating. And as I said, it is associated with LLD, or in this case was, so we used a talospatial frame again and brought it to reverse the tibial slope by creating an anterior apex here, and then lengthen and brought the tibia. So she done well. So there is this rare deformity. You see this in mainly literature from Africa. That this is windswept deformity. So, the initial thoughts are this is probably developmental or syndromic. Quite often these children are only seen 3 in 20 years. Quite often they're dramatic, and there's nothing on X-ray to suggest any pathology. But one should rule out rickets and epiphyseal dysplasias. Unfortunately, they, at least according to literature, they resolve very regularly. But in my case, this child resolved very nicely without any treatment. So my take-home message is that angular deformities around the knee are very common. And as an orthopod, I think you should be able to differentiate between physiological from pathological, particularly in relation to the racial differences. And if you're deciding to do any intervention, please analyze it properly. This is MAP ABC approach, which is mechanical axis deviation assessment, do the joint angles, and pick a bone that is deformed, that is MAP. And then once you pick the bone, analyze the angles and work out where the apex is, do the bone cut, and then plan your correction, either acute or gradual. So that approach generally works very well. So goal of treatment is always the same: restoration of normal axis, length, and function. And there's a whole range of options available, but generally, if the child is still skeletally immature, then guided growth, later on osteotomies. Thank you very much, guys. I think it's 35 minutes or so.
Thanks so much, Mr. Lahoti, for this.
It's a whirlwind tour of deformities. It's a whirlwind tour of deformities, but
exactly, yes, and that's very, very good. We got some maybe couple of questions that if we can. One question about the treatment of genu recurvatum in hyperlaxity patients. Would you go for this? How would you approach this type of problems?
So that's a very good question. Okay, in hyperlaxity, you need to see. I see poliomyelitis with decompensated deformities, and I definitely suggest that we should think of compensating it with bony correction, unless you're dealing with benign hypermobility or some syndromes like Ehlers-Danlos syndrome. But if you have an isolated knee, maybe ligamentous laxity, or in paralytic deformities, where I think we can help the patient. I've got very happy patients where I corrected the recurvatum, so it acts like a block. It doesn't make it normal. Some of these are not braceable. If the recurvatum is nearly 15-20 degrees, none of the braces help. They impinge within the brace. They hurt. By correcting it, either you get rid of the brace or make the brace wearable. So I would be very inclined to do, unless it's primary collagen disease, I would be inclined to correct the recurvatum with bony correction.
Thank you. And another question about the last type of case, which is the windswept deformity. He's asking about what's your treatment for such kind of deformities.
I think, guys, you should probably know much better than I do. Probably you see this more often. I mean, this most of the reports from Africa, and the children I have seen were generally Afro-Caribbean children. But the literature says, there's not that much written. I'm sure our next speaker can give his experience, but do nothing until the child is probably gone through 7, 8, 9, 10, maybe. Then, of course, I'll reach for growth guidance or guided growth, but I haven't got experience. So I'm just giving my philosophy, wait. When you don't know what to do, don't rush. Unless it's tumor, that's different matter. That's my, little bit of experience with 3 cases is not a big one.
Thanks so much, Mr. Lahoti, for this very good discussion also. Let's move to the next speaker, Professor Ahmed Thabet, Assistant Professor of Orthopedics at Penn University and also in Texas, USA. Happy to hear the rotational problems in pediatrics, the lower limb, of course. Go on.
Thank you so much for the invitation. Let me share the screen. Let me see. Guys, can you see the screen?
Yeah.
Okay. So yeah, we are talking right now about I think the previous lecture is very good introduction for the angular deformities in the children. And because most of the time there is a combination of deformities, angular and rotational deformities. Now we are trying to focus on predominantly rotational deformities of the lower extremities in the children. And our objectives today to discuss the common presentations of rotational deformities in children. Number 2, try to go overview about clinical assessment, how to assess the patient with rotational deformities. And lastly, we try to discuss the treatment options, how to customize the treatment according to the presentation of the deformity, according to the other associated deformities, and how to treat these patients with the more complex deformities. Just a little bit of a brief introduction about the embryology of the children, the babies when they're growing in intrauterine. The limb buds begin around the 5th week. The lower leg starts with the feet facing each other and the knee facing out. So, and at certain amount of growth in uterus and the fetus, the leg rotates medially with the big toe facing medially, and the upper extremity rotate the other direction. By the 7th week, the hallux is a midline, as we know, and this is sometimes there is disturbances of the normal growth of the normal rotation of the children, causing the rotational problems in children. And we can see in this picture, the upper extremity rotate to the outside with the thumb facing outside, and the flexors facing the front and the extensor in the back, and the lower extremity facing internally with the flexors, with the extensor facing to the front and the flexor to the back. And that's a very, very important concept. And this is one of the contributing factors why the kids born with the rotational deformities, either the tibia or the femur or both. Subsequent intra-arterial molding causing external rotation of the hip, internal rotation of the tibia, and variable foot positions with the metatarsus adductus, club feet, or other packaging deformities in children. The clinical presentations, so there is a variation of clinical presentation. I see the patient in the clinic, there is multiple ways that kids present for your clinic at orthopedics for assessment of rotational deformities. First group, or the majority of the group, just the parents notice that the kid walking in abnormal way with the feet turned in, or the pediatrician notice when the clinical assessment every year, once a year or every few months for well-being a child for assessment, the kids, just the pediatrician notice abnormal gait and then ask the parents to be evaluated by orthopedic surgeon. This is first or the most common presentation. The other less common presentation is the parents are concerned about the kids' repeated fall and tripping, and they are not coping well with the other kids. And they can see this patient, the x-ray. This is a patient 5 years old, presented to the clinic for assessment for rotational problems. And the kid, prior to this presentation, he broke his radius ulna because he tripped a lot and fall a lot, causing because of the internal rotational deformity with the tibia. And I'll present this case later on. And the other group of patients present with patellofemoral or anterior knee pain, especially a patient with miserable malalignment. Miserable alignment, which means that the femur and the tibia rotate in opposite direction. Was most commonly the tibia rotate to the outside external, and the femur rotate internally with internal tibial increased femoral anteversion. And we can see how much the position of the rotational problems to the femur and the tibia affecting the Q angle of the quadriceps muscles and the patellofemoral joint and contributing to the anterior knee pain. So this is the most common presentation. Other group presentation that the kids present with more complex presentation as skeletal dysplasias as a part of DDH, cerebral palsy, spina bifida, other less common presentation, rotational problem, it will be a more complex, as a part of more complex deformities of the lower extremity or the entire child. So as we discussed with, as a part of clinical syndrome, CP, cerebral palsy, neuromuscular disorders, DDH, or skeletal dysplasias. The clinical assessment is very, very important to try to differentiate what is the source of the deformity. If there is deformity come from the femur, from the tibia, from both, from the feet, and we will go over the next following slides. We will have a clinical approach how to assess these kids with the rotational deformities. So first of all, you have to do the general exam. Look at the child as a whole. Look at the kid. The child has a CP, has a spina bifida, short stature. Is the parents has some sort of in the family genetic limb deformities like skeletal dysplasias, short stature in the family, the parents, the father, the grandfather, the grandmother, all these factors contributing to the your assessment, the family history, and general exam of the child. Look at the stature, look the weight, look at the spine, do the general exam very good. And then if the general exam are good, you go to the next step, ask the kid to get the kid out of the room and examine the child walking. And now we're looking for the foot progression angle. You look at the kid, how the kid walk, and look at the kid walking in a straight line and look for the foot progression angle. You have, after looking at the kid walking, you will have an idea if the kid walking with the feet turned in or the feet turned out, is in toeing gait or out toeing gait. And look, when you look also from the bottom up, from the feet up to the knee, you look at the knee, the position of the kneecap as well, or the patella, and the patella turned in or turned out, have an idea what's the situation. Now, at the end of this gait analysis or observational gait analysis test, with the ask the kid to walk, you look at for the, have an idea, in toeing or out toeing. Normally about the foot progression angle around 15 degrees with the feet turning out 15 degrees to the outside or out external. And the in toeing, one idea, now you have the kid in your mind, your assessment, the kid most likely has in-toeing gait. It could be from the feet, metatarsus adductus, could be calcaneovalgus foot, it could be internal tibial torsion or increased femoral anteversion. Or out-toeing gait, it could be from external rotation or contractures of the hip rotators, and most likely spontaneous resolution by 18 months, or external femoral torsion, or external tibial torsion, or calcaneal varus foot, or foot deformity as well, can causing some sort of out-toeing gait, but most likely the femur or the tibia. And by clinical exam, you look at the child, as you can see, this is the increased or the typical W sitting gait with the kid sitting in this way with increased femoral anteversion. We can see also the kid is standing. Look at the position of the kneecap, and you can see the patella and facing inward on the figure B and facing out of the other figure C. And then by your assessment now, you know what we're dealing with. You're dealing with increased femoral anteversion, increased femoral anteversion or retroversion, or external tibial torsion or intibial tibial torsion. And once you finish the gait, look at the child standing, you examine the kid or the child and do formal clinical exams. You look for the hip rotation, internal rotation or external rotation, look for thigh foot axis, heel bisection line, and we already did the foot progression angle. So we like to do the examination in a prone position with the kid facing the face down, do the clinical exam with hip extension to do the hip rotational profile. So you look this at the midline 0, and now for internal rotation and external rotation, in patient with increased femoral anteversion, you see more internal rotation than external rotation. Child with the external, with hip retroversion, you see more external rotation compared to the internal rotation of the hip. So, and then this is just an idea figure to show the picture between the femoral neck axis compared to the femoral condyle axis around 10-15 degrees, the adult normal femoral anteversion. And the change, usually the number of changes are at the child grow. At birth, around 40 degrees of femoral anteversion, usually correct to 25 to 10 years old. And then the average adult around 15 degrees of increase of normal femoral anteversion compared to the posterior femoral condyles. This is the normal range of motion at the hip. We have the birth internal rotation at 40 degrees, external rotation at 70 degrees. And as the child get more mature, the hip internal rotation and the external rotation usually match up very close to be symmetrical. Internal rotation very close to the external rotation at the hip. Then we know now it is not a femoral anteversion, or by clinical exam, you will know it's come from the femur or not. The second step, you check your thigh foot axis. So you bisect the foot axis from the back to the thigh axis, and then you measure your thigh foot axis. And this will give you an idea about the normal rotational alignment of the tibia compared to the femur. And normal thigh foot axis around -5 degrees. Usually most of the kids around birth are internally rotated, internal tibial torsion. And the age of 10 is positive, or around 8 degrees or 10 degrees. It could range from -5 to 30 degrees, but around 10 degrees. Adult patient are 23, but most of the adults around 15 degrees to 20 degrees at most. And then once you, after doing a thigh foot axis, you will know it's femur or tibia or both. Or also you can diagnose the external, the miserable malalignment when the tibia have external rotational deformity, and the femur has increased the femoral anteversion, and this has caused miserable malalignment with the tibia and femur rotate in different directions. And you look at the feet by examination of the foot, you can have an idea about the metatarsus adductus as well. So this is the normal bisecting line of the foot. And this is also the calcaneovalgus deformity can cause some sort of confusion of the rotational profile of the lower extremity. And as well, this is the clinical exam. But most likely, you will see with the internal or the rotational malrotational deformities of the lower extremity is metatarsus adductus is most common one contributing to the appearance of entowing gait, but actually is not the tibia, is not the femur, it's just the feet is deformed. And metatarsal adductus, most common cause of entowing in infant, represent around 1 every 5,000 births. It's more common in male than female, more common in twins and preterm babies, around 120 in family history. The severity can be based on the flexibility. You can look at the foot and look for the flexibility or the amount of correction you can achieve by passive correction of the foot. And most of the time, 90% resolve without treatment with a spontaneous correction. But also that's one of the deceiving causes for entowing gait, the foot deformity or metatarsus adductus, but give you the appearance of entowing gait, but actually the tibia and the femur have a good alignment. The full examination of the metatarsus adductus, you have lateral border of the foot is curved. The base of the fifth metatarsal is prominent. It may have a deep medial crease, and the hind foot is a normal alignment compared to the club foot with the hind foot inverse. So the hind foot in patient with metatarsus adductus are normal alignment or a little bit of valgus. This is the appearance. You can see if you don't look carefully, examine the patient carefully, you can assume the patient has entowing gait, but actually the tibia and the femur alignment looks good. It's just the feet has a problem with the metatarsus adductus. We'll come back to the increased femoral anteversion a little bit, get more insight about the increased femoral anteversion. Most common entowing, the most common cause of entowing gait between the age of 4 and 10 years old, a little bit older kids. And negative foot progression angle because of the internal rotation of the foot was minus. If you look at the position of the foot in plus, this is for external rotational deformity out-towing gait. So patella is facing medially or squinting patella. That's common at the exam. The test is very common to be tested at this point. And you have marked internal rotation of the hip compared to the external rotation. It's more common in female and then male and bilateral. And the classic is a TV sitting position or the W position sitting of the child. And this is most of the kids sit that way, watching movies, watching the TV, and contributing to the increased deformity of the femur. CT can be helpful. We don't like to expose kids for radiation. Most of the time I rely on the clinical exam. By clinical exam, I will know the amount and the degree of correction I need to do if I need to address with the surgery. So the CT, you can measure the femoral neck axis compared to the posterior femoral condyle axis, and then you can calculate the amount of the rotation. And the bottom picture, just to measure the amount of rotation at the tibia at the intermalleolar axis as well. So the treatment for increased femoral anteversion, most of the time, I say over 90% of the kids, they have a spontaneous correction around the age, up to the age of 8 years old. We don't recommend any intervention before the age of 8 years old unless there is other problems you need to address with the other deformities. So I say peaks around the age of 5 and resolve by age at 8 or 10. Corrects about the age of 1.5 to 3 degrees per year, average around 25 degrees of total correction. Surgical indications, the surgical indication, if there is functional limitation of the kids, we don't treat this just for cosmetic or for appearance or problem, just to improve the position of the foot. If the kid is asymptomatic, have no problems, run, active, there is no indication for surgical intervention. So functional deficit, the patient has anterior knee pain, has limitation, or femoral anteversion over 50 degrees with marked deformities, or patient with hip internal rotation over 90 degrees. And also, if you are not expecting that deformity for spontaneous resolution, we can address it, but we try to focus on the functional limitation as a primary indication for the surgery. And the surgical procedure, most of the time in kids, younger kids with associated with other deformities, we can use proximal femur osteotomies, and usually we use a plate and screws for the derotation osteotomy of the proximal femur. Distal femur, because of the proximity of the distal femur to the patellofemoral joint, we try to avoid attacking doing the osteotomy at the distal femur. Most of the time, what the stuff I do, I usually mid-shaft femoral osteotomy, and fixing it with intermedullary nail fixation. And I usually use a markers, I put 2 Steinman pins parallel to each other and try to know the amount of correction I need to do, or with a saw, oscillating saw, to make a hatch mark in the femur to know how much degree I did correction. 20 degrees, 30 degrees, I don't know how much correction. I need to calculate how much degree of corrections. My goal is to achieve the internal rotation equals external rotation. And this is another tool in the OR, in the operating room, you can use it, the inclinometer, to measure the amount of rotation, also give you objective assessment, how much correction you need to achieve during surgery. And just this, you show a picture how the femoral rotation, this patient has morbidly obese, and she has external femoral anteversion, how much affection.
Make your knee straight.
This is how much, see the patella dislocate with each movement of the knee, and the other side also has bilateral dislocation.
Bend.
We did a clinical assessment to the patient.
Okay.
She also has increased
both
femoral
knees. Can you move both
anteversion,
knees?
or increased, retroversion
Straight.
of the femur, causing or contributing to the patellofemoral dislocation or instability of the patellofemoral joints. And this patient, this is her x-rays showing the patellar dislocations. And this is what we did before attacking the dislocation of the patella. We did a derotation osteotomy of the femur first. And this is what we did for this patient as a case example. She's 13 years old. So I usually start with the marking the osteotomy. I do the multiple drill holes first. And then I use 2 Steinman pins to do the degree of corrections, to know how much correction I achieve. I put the 2 pins parallel to each other. Then I do the reaming, classic reaming for a femoral nail in children with lateral entry nail to avoid AVN of the femoral head. And then I proceed with the femoral nail, and then I do the derotation. And this is the osteotomy after healing. And this is what after, this is the first stage, to do derotation osteotomy of the femur. And then I came back, I did the patellofemoral joint reconstruction, tibial tubercle osteotomy to address the knee or patellar dislocation. And now this is the X-ray showing very good reduction of the patella as well. For the internal tibial torsion, most common cause, it's the most common cause of in-towing in the first 3 years or 4 years of life. Most of the time, 66% is bilateral. And abnormal thigh-foot angle, you put the patient prone, measure the thigh-foot axis, you will see the abnormality of the thigh-foot axis. And also negative foot progression angle, but the patella forward, facing forward. 1/3 of the patient may have metatarsus adductus as well. And most of the most common presentation is a kid fell a lot, trip, and they can injure themselves, or they are not coping with other kids, with running, with being active with the other kids. And most of the time, parents report that kids are clumsy, are not as active as the other kids. And this is the thigh-foot axis. And the treatment, most of the time, you don't have to do anything. Most of the time, just the spontaneous resolution is the majority of patients. Spontaneous resolution by the age of 4, no functional deficit. And some people say that it's advantage. It can cause the kid to be fast and running, but most of the time it compromises the kid activity. And that's a way the parents present for orthopedic surgeon to do something for the deformity. And this is the kid I present initially on the clinical assessment. This is the kid. There's very few kids I did surgery for this deformity. This kid presented, the mom is a nurse, 5 years old. He tripped a lot, fell a lot, and he broke his forearm fractures and causing radius and ulnar fractures. So it's functionally limited, very active kid, to the degree that he broke his radius and ulnar fractures. So we came back, we did a distal tibial osteotomy and fibular osteotomy to correct his increased tibial torsion and fix it with internal fixation with anterior plate, small plate. And usually if the the rotation, if you need correction over 30 degrees, you have to do the osteotomy of the fibula. If the rotation is less than 30 degrees correction needed, you don't have to break the fibula. So that's a technical tip for the correction of these deformities. This is another kid with the spina bifida. She's a walker. She has a muscle weakness on the gastric and the peroneus longus and brevis. The only muscle is working is tibialis anterior, causing dorsiflexion with the inversion of the ankle. And she has also increased tibial torsion of both tibias, and with a corrective osteotomy of both tibias with internal fixation with a plate and screws. The advances in the nail of the femur, the nail and the femur are very good because allow the kid early weight bearing, and the tibia, because we don't like to violate the proximal tibial physis, and there's no good nail to do the rotation around the nail. We usually use a plate and screws or external fixators to address the tibia rotation of the tibia. That's the difference between the tibia and the femur. Metatarsus adductus, you can, if the deformity is mild to moderate, you can do the casting for correction of the deformity, but operative intervention is only reserved for severe cases. Most of the kids like either soft tissue release or foot osteotomies to correct the metatarsus adductus if the metatarsus adductus is the reason for the in-toeing gait. So if we just to try to summarize what we said, so most of the time, 99% of in-toeing resolve by itself. So you don't have to worry about too much. They have to reassure the parents, continue to see the kid once a year to make sure the correction is achieved. You have to educate the parents that no corrective shoes, no braces, no cables, no wedges, or some kids put the right shoes in the left foot or the left foot in the right shoes, but this is it doesn't contribute. The only thing that corrects this deformity is just as the kids grow, the deformity improves by itself. There is no need for physical therapy. There is no medications. There is no braces. In-toeing could be from metatarsus adductus in infant. Younger child is tibial torsion. Older children, most time is femoral anteversion. Out-toeing, it's external rotation, contraction of the hip, or increased tibial rotation. And you have to watch for out-toeing for scaphy. It can contribute to scaphy, slipped femoral capital epiphysis, or also look for patellofemoral joint. The Q angle of the patella can also be disturbed by external rotation deformity of the tibia. You have to watch for this. Patella is highly influenced by the position or the rotation deformities of the tibia and the femur. Thank you so much. Any questions?
Thanks so much, Professor Ahmed Thabet, for this wonderful, informative, and conclusive talk. Really, you have put the light over the most common rotational problems and how would you assess this clinically and how you treat it. One question about the miserable malalignment.
Yes, the miserable alignment when the femur and the tibia rotate in opposite direction, which the femur rotate internally or increased femoral anteversion, and the tibia rotate into the other direction at external tibial torsion or external rotation deformity of the tibia. That's a miserable alignment, cause too much stresses to the patellofemoral joint, and most of the time the kids present with anterior knee pain.
Okay, there is another question about the effect of the correction on the extensor mechanism by increasing the femoral anteversion, proximal or distal femur. Effect on the extensor mechanism of the knee?
Yeah, that's why we tried. I mean, I usually don't do any corrective osteotomy in the distal femur. I try to avoid the disturbance of the patellofemoral joint and extensor mechanism. So I usually recommend to do either proximal femur osteotomy or mid-shaft osteotomy. If the kid is very young, I say 5 years old, 6 years old, I do proximal femur osteotomy. If the kid is old enough, I can do old enough to use a femoral nail, I use mid-shaft osteotomy for deformity correction. I don't do any distal femur osteotomy for this problem, the extensor mechanism.
Yeah. And if there is associated limb discrepancy with the rotational deformity, generally speaking?
Yeah, if this is a complex deformity, as the previous lecture said, that's angular deformity, limb discrepancy, and rotational deformity, you have two options. If you have access for external fixators and you're comfortable using the X fixes, you can use them because X fix can correct rotation, can correct angular deformities, can correct the length as well. But recently, in the recent few years, we have access to lengthening nails, precise nails, or the magnetic nail for lengthening. Now we shift the implants from X fixes to internal fixation magnetic nails. I can do rotation around the nail. I can do acute correction of angular deformities around the nail, and then I do gradual correction for length, for equalization of limb length. The magnetic nail, fit bone nail, or precise nail for lengthening, I can also another option for correction.
What about doing corrective assessment in the tibia and just do cast without internal fixation?
You can, of course, you can. Definitely, it is an option. It depends on the resources, but you have to look for the other. The cast is good, it's safe, but remember, cast, you do osteotomy, do rotation of the tibia, it may create compartment syndrome, especially with casting. You have to look for the swelling and the tourniquet and the correction. You have to look for compartment syndrome. Number two, you have to delay, or most of the time, you have to wait for weight bearing on the limb. If I use a nail, I let the kid walk right away. I'm comfortable with using the nail and allow the kid to walk on his operated limb right away. But if you use cast, you will delay weight bearing, delay the recovery of the child. But it definitely is an option. I used it before. It's a very good option. But you have to look for the other disadvantage of cast.
Yeah, we'll take. There are some qualifications, but we don't want to overrun the time. The age limit when you consider using a nail to fix the femoral corrections.
So we have, of course, I mean, I'm not sure you are familiar with using the piriformis nail in children causing AVN, and this is not recommended. Now there is a new implants, lateral entry nail, which you go from the center of the greater trochanter down to the femur. So if you use this nail, the minimum age you can use for lateral entry nail is 8 years old older. So 8 and older, you can use lateral entry nail for deformity corrections. But you have to make sure which nail you have, because not all nails have a lateral bend to allow you to go into the femur.
Yeah. The last question: if there is a rotational deformity with no functional problem, when would you treat?
If there is no condition, no pain, the kid's running and active, I just watch it. There's a lot of people you can see in the street, in the malls, and everywhere that kids have patient with internal rotation, and they function very good. I just observe the patient.
I think that's enough. Thank you so much, Professor Thabet, for this very good and inclusive talk. Now we are going. Sorry?
Thank you, Ahmed Thabet, for being with us tonight.
No, of course, it's my pleasure. It's my honor always to be with you guys. Thank you so much for the invitation.
Thank you. We now want to introduce our dear friend, Professor Mohamed Antar, is one of our professors.
أحمد ازيك؟
الحمد لله. محمد حبيبي.
ازيك يا ابو حميد؟
وحشني.
وحشني
جدا.
الحمد لله.
عمر عامل ايه؟ تمام؟
الحمد لله.
سلم لي عليه.
So, Prof. Antar, would you like to share your screen, please?
Yes.
We're waiting for your share.
Okay.
You are with us, Antar?
We can't see anything.
Yes.
Is there any problem with sharing screen, Dr. Antar?
Yes. I'll solve it.
Take your time.
Okay.
Yes. Full screen, please.
Perfect.
Firstly, I'd like to introduce myself as one of your student, Professor Dr. Ahmed Allam, and my colleague, Prof. Ahmed Thabet. He was my senior in Banha Medical School. And my colleague and my young brother, Dr. Ahmed Sheikh, and our Professor, Dr. Mohamed Al-Ashhab. Are you listening to me?
Yes,
Yes,
loud and clear.
your voice is quite well.
I would like to do an assessment for complex lower limb deformity. I want to introduce a clinical assessment for complex lower limb deformity. Our concept, successful limb reconstruction surgery, not only relies on surgical skill, but more on preoperative assessment and planning. Understanding of natural history of the disease, careful evaluation of the patient clinically are the key to successful treatment. Deformity analysis, data extraction, treatment plan require experience and training. A systemic evaluation of the child must be followed. History, clinical examination divided into observational gait analysis, alignment, joint examination, rotational profile, limb length measurement. Number 3, investigations, imaging, modeling, gait analysis. History, the key points are identification of current problem, clarification of diagnosis, previous treatment, effect of growth over the deformity and its progression, effect of the deformity on daily activities of the child, parents' expectation, psychological situation of both patient and their parents, then the financial situation of the family. Clinical evaluation divided into careful clinical examination essential to minimize the potential to miss the important findings. Younger children, always examined by observation, may need second or third consultation, may be required for the child examination to be more comfortable for the examiner. Number 1, observational gait analysis. Patient must be exposed. Patient must be examined from front, back, and sides. Examination both walking and running. Begin observation from proximal by trunk and end by the feet. Gait analysis. 4 questions should be answered. What is the progression angle? Which part of the foot touches the ground first? If there is clearance during sewing phase, or the 3 rockers pattern is present. This is what's called foot progression angle. At the middle, it is neutral. It is 0 degree. Proximal in towing gait and distal external towing gait. This is the normal cycle. First, stance phase, heel strict, foot become flat, mid stance, then push off, then acceleration, then swing phase, mid swing, deceleration. This is what is called normal rocker pattern during stance phase. Heel rocker first, then ankle rocker, and the tibia is rotated upon the talus, then the forefoot rockers, the third and the last. This is normal rocker pattern during stance phase. Number B, alignment. Patient examined in standing position from front, back, and sides. Examination of the spine, pelvis, and the lower limb should be done carefully to clarify the site of the deformity. C, joint examination. Joint is so important. We examine 2 things in the joint: joint motion and joint stability. Assessment of joint range of motion and stability are important. Joint contractures could be part of the disease, as the polio, arthrogryposis multiplex congenita, or compensatory to the original disease, to the other deformity in another levels. For example, Genu varum, which compensated by foot pronation, and valgum, which by foot eversion. This is the axis which I'll talk about: Genu valgum and Genu varum, foot pronation and foot supination. Joint examination, stability. Stability is much more important. Maybe due to bone, joint instability may be due to bone, soft tissue problems, or both. In simple cases, examination and imaging can clarify the etiology. In complex cases, specific imaging, examination under anesthesia, with or without arthrography, could be needed. For example, if you have unstable hip joint and you try to do femoral lengthening, it is very, very dangerous for the patients. This picture shows arthrography of the knee, which show the sloping, anteroposterior sloping, and medial sloping of the medial tibial plateau. Number D, rotational profile. Coronal and sagittal plane deformities are easy to evaluate, but axial rotation have a major impact on the deformity and always underestimated in clinical examination. So, like my colleague Ahmed Thabet said, rotational deformity impact on the patient and underestimated in clinical examination, also in literature. The helio profile is
Hello,
Dr. Antar?
Dr. Antar.
I think there's a problem with the
Dr. Mohamed Antar, still with us?
Connections problems. Ahmed, can you call him on the phone?
call him, Dr. Ahmed. Call him immediately.
Can open for questions. Anyone have questions for his lecture till he comes back? Come back.
Hello. We see the screen, but we cannot hear any sound.
You called him, Dr. Ahmed Sheikh?
Yeah, I tried.
yes,
The
Ahmed.
network is poor. Yes.
Hello, Ahmed.
أيوة. تفضل يا باشا.
Sorry, so this patient
The sound
Ahmed.
stopped again.
يعني
بيقطع يا فندم، معلش كمل كده اتفضل.
This patient have traumatic middle and lower 1/3 of the femur. The patient has severe internal femoral torsion. We have an hysterotomy and application of TSF. Firstly, we do correction of the rotation deformity. Then we do lengthening for this patient. This is about the question which was asked for my colleague Thabet, which about what to do. If you use external fixator, it can simultaneously correct the rotation and lengthening and angulation. This patient, after correction by TSF, Limb length discrepancy was corrected. Internal tibia torsion was corrected. Return back. Limb length measurement. Let the limb length assessment to be the end. The end, and the last thing to be think about is limb length discrepancy, because joint stability and condition will direct your decision. If you have joint unstable, the limb length correction will be danger for this joint. Limb length measurement. Limb length discrepancy could be true due to bony loss or shortening, functional or apparent due to joint contraction or instability, or combined. In patients with true shortening, blocks of various size could be used to measure the true shortening. In case of functional lower limb discrepancy, the measured with a tape from the corresponding bony points over the tilted to overcome the tilted pelvis. Usually, we use the anterior superior spine to the center of median malleolus. This is the two corresponding points on both right and left lower limb. Imaging like CT scanogram is helpful in difficult case. This is a very difficult case. This is what I'll talk about. This is a case of proximal femoral focal deficiency. The head, small head inside the joint. How to do lengthening? This is very, very big problem. Investigations, medical imaging. The mechanical axis radiograph is highly important in deformity assessment and treatment planning. Direct connection between the radiographer and the surgeon is mandatory to ensure the correct image request. Medical imaging. Patient should stand balanced, patella facing forward and the feet forward, knees in normal extension. In case of limb length discrepancy, blocks are put under the affected limb foot to level the sacrum. If the patella subluxed, put the intercondylar axis of the femur parallel to the plane of the film. Try to decrease the rotational deformity effect by put the feet forward. Common forms of mechanical axis imaging: telentogram, 1 mm film, tube film, distance 3 meter, CT, EOS parallel beam, 2-dimension, 3-dimension image capture. A specific radiograph investigation may be required for joint in case of joint affection, and may also include the use of stress view and arthrography. Axial imaging is used to assess 3-dimensional anatomy and rotational alignment. It is efficient in evaluation of complex deformity. 3-dimensional instrument gate analysis. It is technically demanding process with highly trained staff. High quality video combined with kinematic and kinetic data can greatly help understand the cause of gate disturbance. This is EOS. This is 2 sources of X-rays, which can give you X-rays to the whole body, including pelvis and spine, with low level or low dose of radiation. Pedobariography is a method for studying the changes of the pressure carried out by the foot during stance phase. Perispecs standing platforms are sample devices that clearly show static pressure disturbance and can help clarify the degree and the type of correction required. This is perispecs, standing plates, and this is the picture of the foot where is different types of pressure upon the foot, and if it is pronation, supination, or normal. Modeling. Axial imaging from PCT and MRI can be manipulated to produce virtual 3-dimensional image of bone, joints, and specific soft tissue structure. This image can be used to produce a range of printed models. None of these techniques should be used as an alternative to careful examination and experience. Here in Egypt, some of the radiographical centers now take CT of the fractures and make a plastic model for the surgeon to do examination and planning. Summary. Data obtained from history, clinical examination, and investigation should be analyzed to perform a treatment algorithm specific for each patient. Question you must answer. Limb alignment. Does the deformity affect the axis of the limb? Which of which? Does the deformity affect the axis of the bone, or there is deformity in the joint? The deformity, limb alignment, is the bone is the cause or the joint is the cause. Which is the cause of joint deformity? It is traumatic, congenital. Identify the deformity. Where is the rotation axis of the deformity? Clinical and radiological analysis should be performed both coronal, sagittal, plane, taking into account any rotational deformity. Virtual surgery can be deformed into 3D various techniques, and the implant tests. The results of the correction plan are reviewed. Message delivered at home. We must understand the natural history of the disease. We must be reconstructive for the patient rather to be a destructive. Are we sure of the final analysis of the condition? What are the alternatives for the treatment? Are you qualified to perform the procedure or not? This is our published papers. This is a combined malleoplasty. We use pterospecial frame with medial malleoplasty in the cases of varus deformity of the foot with lost medial malleus. This is also one of our papers. Management of adolescent tibia vara using Taylor special frame. We do good analysis for the complex deformity in these papers. At last, stick to the rules while doing diagnosis. Try to do some imagination while doing planning and treatment. Thank you.
Thanks so much, Professor Mohamed Antar, for this very holistic talk. It's about the holistic approach, how to deal with the complex problems. And it's very, very important that not to look at genu varum or genu valgum or rotational problem as isolated problem. You should look at the whole patient to be able to be delivering the proper treatment. I really thank you so much. This is much appreciated.
Thank you. Thank you. Thank you.
You are welcome. I don't think we got some question for this talk, but there is a question from the previous talk that you can also give your experience about it. What is the, that's fine. So one of our dear panelists has replied in writing. So that's fine. So we are clear now to go. Thank you, Professor Mohamed Antar again. Prof. Alam, if he likes to introduce Mr. Nayagam for the last talk.
Yes, another part of the tart, another sweet part. Our dear friend, Professor Durai Nayagam. Are you ready, sir?
I am. I'm just going to try and share my screen.
Yeah.
And just to confirm that you are seeing the view and not the presented
Yes, we
view.
see it.
Yes, we see the presentation only. Yeah.
Oh, good. Thank you again for inviting me. Ahmed El Sheikh, I'm sorry I answered the questions. I thought I could help by answering some of the questions.
That's fine. That's absolutely perfect. I really appreciate it. Thank you.
So I have a presentation to give you an overview of guided growth and deformity correction by guided growth. This is a very general lecture, so it is one that will, for those of you who are on the course, who are starting out, just want to know a little bit more in depth about guided growth correction, this will be a useful lecture for you. No competing interests to disclose here. So this method of treating deformity only works in those who are skeletally immature. And it's important to remember that it works by creating a differential rate of growth across a physis. And so if one side of the physis is growing at a different rate from the opposite side, you create, in effect, an alteration in shape as the physis adds to the length of the bone, and that in turn can correct a deformity. Another term that people use is hemiepiphysiodesis. And most methods that we use today are temporary methods, although there are permanent methods as well. So the temporary methods, there are really three main groups. There are staples that you can use, there are tension band plates, and there are screws. So I'm going to cover each one a little bit just to give some perspective to this method of treatment. Okay, so the technique of modulating, influencing growth around a growth plate, around a physis, was actually started by Phemister, but the man who is credited for making it a clinically successful method of treatment is Walter Blount. And his first initial series was published in 1949, where he described using, through oblique incisions around the physes of the distal femur and the proximal tibia, inserting parallel groups of staples. And these were originally stainless steel and later became Vitalium, which is another alloy, because he found that they were more resistant to breakage. And the reason for using multiple staples was so that you could be sure there was an effect on growth. So to actually get that sort of guarantee that you could get an effect on growth on that side of the physis. Now, I will come back to staples a little bit later on because much of the work done by Blount has still great relevance for guided growth users today. But this man, Peter Stevens, in 2005, introduced a much less invasive and a much more user-friendly way of modulating growth. And this was the 8-plate or tension band plate. The principle is very straightforward. By putting a non-rigid, this is the key, a non-rigid device on one side of the physis, it was able to influence growth without fatigue fracture. Because this device was flexible, it allowed some separation or some distortion of the implant as the growth occurred, but the growth was much less fast than the opposite side, and so created a hemiepiphysiodesis effect. Now, the other huge advantage compared to staples is that the learning curve of performing an 8-plate procedure by Peter Stevens, his quote is, "It takes only one case to do." And it is a very straightforward procedure. There are some important tips that I'd like to share with you. It's essential that the entire procedure is performed with C-arm guidance. And normally, and I'll show you some pictures of how I do it, I would try and locate the physeal level, if it's distal femur, proximal tibia, using the C-arm. I will then ensure I locate the center in the AP direction, anteroposterior direction of the physis, and I will mark this on the skin. So here you can see one mark for distal femur, one mark for proximal tibia. The incision is very small. It's usually 15 millimeters, at the most 2 centimeters, because the skin can move proximally, distally, anteriorly, posteriorly to allow you to slide the implant in. So it doesn't need to be as big as the implant. But the most important thing about the dissection to insert this tension band plate is that you must keep your dissection extra periosteal. The reason being is if you damage the periosteal, you're in the region of the physis. So you're likely to damage the perichondrial ring. And if you do that, you are more likely to create a permanent tether and not a temporary tether to modulate growth. When you get the right plane, which is the extra periosteal plane around the perichondrial ring, I usually try to locate the center of the physis with a hypodermic needle. And I put this hypodermic needle through the central hole of the 8-plate device, as you can see here. This allows me to center that 8-plate on the physis. Once that is done, I will then negotiate that 8-plate down into the perichondrial ring layer. As you can see in this X-ray, you can see the central needle, the very fine needle that's pointing into the physis, and then I insert guide pins or threaded guide wires through the holes of the 8-plate to ensure, by and large, that these guide wires are parallel to the physis at the point of insertion. If you all remember, the physis of the distal femur and the proximal tibia are not straight lines. They are in 3 dimensions, curves. So the physis is not parallel to the joint line, it's parallel, the guide wires are not parallel to the joint line, it's parallel to the physis at the point where it's inserted. And you then follow on with a drill and insert the screws to finish the operation. So the learning curve is straightforward. It's one case. And here you can see it's been done for the femur and the tibia. The commonest indication, and we've heard this from the previous speakers, including Om Lahoti, is for coronal deformities around the knee. There are extended indications. You can use this in the distal tibia. Some people have even used it in the elbow, but I'm going to focus on common indications, and coronal plane deformities around the knee is the commonest. So here is an example of Genu valgum where the 8 plates growth modulation is being performed on the faster growing side. And the easy way to remember is it goes on the convex side of the deformity. Always apply this technique on a working physis. In other words, the physis has to be working throughout. If the deformity is caused by an abnormality of the physis on the opposite side, then putting an 8-plate or a staple on the convex side will not correct the deformity. All it does then will be to stop the deformity getting worse. Here's another example of hypophosphatemic rickets where an 8-plate has been used and the axis has been restored. If you were to measure all the angles for this particular case, you may find that the angles are not completely within normal deformity. The axis is normal, and this is what matters at this particular time. So this in many respects is a correction, but it's a compensated correction that gives you a much improved axis, but without normal angles all the way through. The key questions that you need to answer, and the answers that which you need to have when you're doing this technique, is what are the optimum ages for doing guided growth? How fast does it correct when you've inserted, say, a tension band plate? How long can I keep the plate in for? And what happens after we remove the plate? So let me try and answer these questions step by step. Quite simply, the speed of correction is proportional to the speed of growth. So if you now look at the growth charts for boys and girls, you can see that there is an exponential rise in one part of their growth, and there is a plateauing in another part of their growth. If you look at girls, the exponential part is usually between 9 and 13 years. And if you look at boys, it's usually between 10 and 14 years. So quite simply, after the age of 8 years is a good time to consider using this treatment. It can be used earlier and it can be used later, but the caveat about using later is you should usually ensure that you have at least 2 to 3 years of growth remaining, because if you don't have enough growth remaining, then guided growth will not have enough time to achieve a full correction. What is the rate of growth after insertion of the implant? Well, actually, this is why I said we'd come back to Walter Blount, because Walter Blount found the answers of this through following his patients. You remember when I presented his first paper, when he introduced the technique using staples, that was 1949. Another important paper he published in 1971 documented his experience of the technique. And he found, by following his patients, that about 50% of growth retardation occurs in the first 6 months, and then it increases to about 80%. We also found a similar effect using the 8-plate. We've done well over 250 cases in Liverpool now, but our first 25 patients So it was a very early experience. We published in 2009, and we looked at 51 phyces that were treated with the average age of insertion around 12.5. The youngest was over 5 years old. And these were cases of Genu varum and Genu valgum. And what we found that the speed of correction in the femur was about 0.7 degrees per month. In the tibia, about half a degree a month, and the sum of the two being the overall correction. But we also found much faster in the younger child. And this would match with those exponential parts of the growth curve that I showed you earlier. How safe or how long can you safely leave this device, this plate in place before you run the risk of creating a permanent tether? And generally the advice should be around 2.5 to 3 years, no more than that. If you've got a very large deformity and you cannot complete the treatment in 2.5 to 3 years, then it may be advisable at around 2.5 years, take out one screw so that you give a rest period of 6 months to a year, and then reinsert the screw to start the correction going again. So these are ways in which you can try and protect the physis from generating a permanent bar or a tether. Two conditions that you really need to over-treat or over-correct because they have rebound. That is Blount's and Cosen's phenomena. So for Blount's disease, you want the mechanical axis to go towards the lateral side of the compartment. And in Cosen's phenomena, which is usually a Genu valgum, you want the mechanical axis to be in the medial compartment slightly before removing the plate. Another important contribution by Walter Blount, 1971. He confirmed growth resumes after removal of these devices. And that is the same whether you were using multiple staples or if you're using the 8 plate. When does this technique not work? Well, quite simply, it doesn't work if you've got a sick physis or if you have a physeal tether that either you knew about or you only knew about it when you applied an 8 plate and found that it didn't work. And then you looked a little more carefully and found that there is a tether on the other side that's not working. This idea, this concept of a sick physis is actually a diagnosis by exclusion. Usually it's a case of using guided growth, and you find the guided growth is not working even though there is no tether. And these are usually physes that have been exposed either to treatment for cancer, etc. Some of the treatments that have been used for cancer or associated with hematological disorders, they tend not to respond as well. So you have to be careful. There are some conditions in which guided growth does not work. So here is an example of Blount's, bilateral Blount's. On the left leg, we used an 8 plate, and you can see here we've achieved correction, but on the girl's right leg, it has not corrected the deformity. On one side, the Blount's obviously had a tether and the other did not. The last method I want to talk about is the transphyseal screw technique by Jean-Paul Metizot, also known as PETS, percutaneous epiphysiodesis using transphyseal screw. He described this in 1998, and he described different configurations of screws. Some are applied for achieving growth arrest for treatment of leg length inequality. So as you can see here, the cross screw or non-intersecting screw techniques are really to create tethers in the physis to stop the contribution to longitudinal growth. But you can also use single screws to try to treat coronal plane deformities with this technique. I have used this technique sporadically, but I was not as comfortable using this technique as I have been using the 8 plate. And my reservations were reinforced when several papers were published suggesting that the technique does have some issues with complications. Here in this paper that was published in 2012, where the technique was used for growth arrest for leg length inequality, the growth modulation was only achieved in 2/3, and some of them developed deformities. Also, in a paper published in Strategies in Trauma and Limb Reconstruction from Sheffield, they found that in using either the Metizo method of percutaneous screws versus the Canale method of drilling through the physis and scraping out a track, they had less complications, fewer complications with the Canale method in comparison to the Metizo method. And it's also worth remembering that the Blount and the 8-plate technique and the Metizo screw techniques, although aimed to try to achieve growth modulation, they're not doing it the same way. Blount and Stevens are actually trying to achieve physeal modulation. The physis in which the device is applied to is still growing, but it's not growing as fast as the other side. Whereas the Metizo screw technique is a method of physeal arrest. It's trying to stop the physis from growing. So the precision of that screw, the position of that screw is critical. If you get it wrong in the 3-dimensional space, you're probably going to get a deformity. So to conclude, what are the indications and limitations of using guided growth? Well, the most common indication, which most surgeons will use it, will be for coronal plane deformities around the knee. I've already shown you that during the rapid phase of growth in children, slightly earlier in girls than it is in boys, but both of them after the age of 8 is a good time to start using this technique because you get rapid correction. Always try to check before you recommend this treatment that the other side of the physis, you're applying this on the convex side of the deformity, make sure the other side of the physis is actually working. And finally, there are 2 conditions you must remember to overcorrect, because it will be embarrassing if you get it perfectly, the mechanical axis in a perfect position in Blount's and in Cozen's phenomena, take the 8-plate or the staples out, and only to find that within 6 months the deformity rebounds and recurs. The most important take-home message I will and also one other important point is to try to leave the implant in no longer than 3 years. And I've also mentioned about the rest period by taking 1 screw out from an 8-plate. The most important message that I should leave with you at the conclusion of this presentation is do not treat a patient who cannot be followed up. And this was advice given by Walter Blount. If you have treated many patients using guided growth, you will almost certainly have come across a patient who failed to attend a follow-up appointment only to turn up 6 months to a year later and find that they've overcorrected. And that is very embarrassing. So always at the start of treatment, emphasize to your patient, you must attend follow-up. And in Liverpool, the follow-up schedule was every 4 months with an X-ray. Thank you very much.
Thank you. Thank you very much, Mr. Durai.
Thanks so much, Mr. Nayagam, for this wonderful talk as usual. And it's again about the principles. Let's take a couple of questions. We will not be long. What about guided growth in other conditions like hallux valgus?
Well, I suppose in theory you can. I do not know of a device as yet in hallux valgus. In many cases, you can apply it to physis using the same, but currently the devices that are available are the plate and the screws. But in theory, yes, but I would not be advocating it. I've not used it for hallux valgus.
Sagittal plane deformity around the knee?
And you would need a physis that's growing. So why would you be using this in a child?
Yeah. Sagittal plane deformity, recurvatum, procurvatum. Any experience with using 8-plate to correct this?
Yes, I've used the 8-plate in the femur to correct recurvatum and procurvatum. You don't have to put it anterior. You put it medial and lateral, but you just shift the position of the 8-plate either slightly anteriorly if you want to correct procurvatum, or slightly posteriorly if you want to correct recurvatum. So it actually works quite well in the distal femur. I've not used it in the tibia.
Yeah. And if you are worried about the other physis, is it growing or not? How would you make sure of this?
So, like everything else, you can start first by taking a history to see if there's any past history to suggest a reason for there being no a physial tether on that side. If you are suspicious, then you can use imaging, either an MR or CT. So those are certainly in Blounds. I have a very low threshold to do an MR because I'd like to see if there is a physial tether beginning to develop. They all develop physial tethers with age. It depends at what age they present to you. And I like to see what the state of that abnormality in the growth plate is like.
Talking about the age limit for temporary hemophysiodesis, like 14, 15 years old, does it stop you
So
from
I will
considering
always do a bone age. I will do a bone age. So it's not by their age of, by their date of birth, but a bone age. And I would play safe. I would say you want at least 3 years of growth. So for a girl, you want to start, if the bone age is about 11, I'd be happy to start. And for a boy, probably around the age, because they grow till 16. So I'll probably start at around the age of 13. No later than that.
No later than that, yeah.
Yeah, but by bone age. By bone age.
Bone age. Two good questions about the technique. But what about the length of the screws? To what depth you should reach? Half of the physis more or less, and the configuration, divergent,
Okay.
parallel.
So it's not critical. And I've had this confirmed by Peter Stevens. You can even mix the screws if you want to. It's not critical. Much more critical is the position of the plate. You want it to be bridging the physis and central in the AP direction.
Yeah. One of the colleagues asked about the third tubular plate. You cut it, use it as 8-plate. Would this work in some way, or a recon plate in some economically restricted areas?
Answer is yes to both. And Peter Stevens himself has said that if you cannot afford the proprietary plates, just a recon plate. The recon plate has oval screws. It's a weak plate, so it's flexible, and just use standard screws and it will work just as well. Obviously, you don't have the facility for using the guided pins and the central needle technique, but it takes a little bit longer, but it works. And it's a good technique to remember if the patient cannot afford the more costly proprietary implants.
Yeah. I know we talked already about the age limit, but one question about menarche. Is that indication of no further guided growth will be used, or there will be some time left after menarche as a sign?
I use the bone age. I don't use the menarche. I use the bone age.
Okay. I think one last question, Coxavara.
Peter Stevens has published using that. And again, within the time limits of 20 minutes, we could talk about the proximal femur, we can talk about sagittal plane, we can talk about the ankle and the elbow. But because of the time limits, we couldn't cover everything. But yes, the answer is Peter Stevens has published about using this for Coxavara.
I think that's enough. Thank you so much. We have done so many questions, and this would be a bit late for you. Thank you so much for all the speakers, Mr. Lahoti, Mr. Nayagam, Professor Ahmed Thabet, Professor Mohamed Antar, Prof. Alam, and then shall we conclude the session?
And thank you to you all.
Thank you very much. Good luck for the rest of the course.
Yes, we
Tomorrow
got
is
one.
another important day.
Yes.
We will talk about infections. This is very important day. I am inviting you all to attend, please. We will be happy if we see you tomorrow, inshallah.
Thank you.
Thank you,
night.
all of you. Thank you. Goodbye. Have a good night.
Bye-bye.
Bye.
Thank you.
Bye-bye.
Thank you, sir.
Bye.
Thank you.